Perfect, that's great, thank you. So welcome to Vision Arcade. Thank you very much for taking the time to join us on the second webinar that we're doing this time round, and hopefully it will be of benefit to you guys all. So like my colleague said, my name's Iman Jama. I'm one of the optometrists based in the UK, and I'm going to be talking about low vision today. Now, low vision is a very, very big topic, and unfortunately for the time allocated, I won't be able to cover everything surrounding that topic, basically. So I will sort of be talking of the background and sort of basics of low vision, but mainly it will be talking about case history for a low vision patient. So yeah, just to go over the contents, I'll be going over sort of definition, causes of visual impairment, prevalence, and then just the beginning of the low vision eye exam as well. So some people might be wondering, why do we have to sort of talk about low vision? Well, for some of the students with us today in the attendance or audience might say, you know, the only reason why I'm here and I want to learn about it is to pass my exams. Yes, that's important, but it's also it's a deep topic that makes a massive difference to a lot of numbers and patients that we see, which we'll come across so shortly in the presentation as well. It's also to provide support for vulnerable patients and equipped you to deal with future demographic changes. So obviously with time, you start to get older and older, much larger, older populations, and some of those will become low vision patients. So it is important that we are able to deal with those patients and sort of help them and give them the support that they require. So just to start off with a definition. So what actually is low vision and how do you define that? So low vision is sort of patients with reduced visual acuity, which even with the best optical correction provided by regular lenses, still results in a visual performance on a standardized clinical. So you're always comparing it to what's expected of that person's age. And by impairment, we simply just mean that the reduction in the performance is below than what's expected, basically. So most developed countries will sort of have like a social care system which provides support and benefits to these groups. And typically they need to be registered in order to be able to be eligible and access that welfare benefits. So registration sort of acts as the patient's passport to be able to gain access to those benefits. And therefore you need some legal definition of blindness or low vision. And the definitions of blindness that were used varied from country to country. So in 1966, WHO sort of identified that there were over 65 definitions being used across the world. Typically terminology was sort of similar, but the criterion sort of in which they were identified varied greatly. So some places, including Nigeria, sort of had economic blindness, social blindness, educational blindness, professional blindness, practical blindness, etc. So with all those different criterions and terms being used, how do you sort of facilitate it, or sort of how are you able to sort of define it and have one uniform or universal sort of definition? That's when the International Classification of Diseases sort of came about. And that was in 1975. They came up with a definition, and the aim of it was to facilitate the collection of international stats and data on visual impairment and blindness in a uniform manner so that it can be compared at a global level. So let's say if the definition used in the UK varies sort of to the definition in Nigeria or other parts of Africa, how are we able to compare the stats and the data that's being collected? So that's the aim of the ICD, or the International Classification of Diseases definition. And in terms of how they've defined it, so what they've said in terms of low or mild visual and then moderate is classed as 618 or worse, severe at 660 or worse, and actual blindness at worse than 360. And then in terms of near vision, it's anything that's worse than N6. So countries were advised to sort of define blindness as per their own social and economic conditions, but in terms of reporting it back, they had to report it internationally as per the ICD categories, which we sort of just looked at. So also in certain countries, such as the UK, they sort of have like a dual category. So in the UK, it 360 or anything that's between 360 to 660 with restricted visual fields, or anything that's 660 or better with a gross field defect. So it's not only just based on the actual visual acuity, but also how does that correlate with their visual field? Is that restricted or not? And then in terms of partial sighted, which is a little bit better than blind, it's 360 to 660 with full visual field, 624 or worse with moderate field loss, and then 618 or better with a gross field defect. And this is what's used here in the UK in terms of registration and registering low vision patient. And that's the two categories they are divided into. So initially it was called blind, and that's sort of been changed to severely sight impaired, and partially sighted has been also sort of classed or called sight impaired. So I just want to quickly go over 3 different scenarios, or if 3 patients presented to you and you were to register them, how would they be registered? So I've kept the categories or the definitions on the side there, and we should have a poll on this, hopefully. Let's see if it works. So if we can just get the poll up. So I'll just show you the question, which is patient A presents. So let's say patient A is a 75-year-old patient with wet AMD. Their visual acuity in the right eye is 636 and left eye is 660. In terms of visual field, both eyes, they have a central and below fixation scotoma, or basically, in other words, a blind spot. So if this patient presented to your practice, you've got the categories there. What categories do you think, or what category would they be registered in? So if we could just get the poll up, that'd be great. Sean, are you able to get the poll up? I don't know if you guys, oh, there we go, perfect. So yeah, so I'll just sort of give you a minute or so just to have a look at the question and answer it. So that's the patient that presents. What category do you think they would be eligible to register in, as blind or partially sighted? Perfect. And then if we could just get the responses. That's great, thank you. So 36% said severely sight impaired and 64% said sight impaired. So the correct answer is actually severely sight impaired. And that's the category they would register in. Perfect, thank you. And then we've got patient B. So same again, but we have a different patient this time. So it's a 52-year-old patient with diabetic retinopathy that presents to you. Their visual acuity in the right eye is 6/120 and left eye is 6/36. They have moderate restricted field in the right eye and their left eye field is full. And also, sorry, I forgot to mention that this is based on their better eye. So you're always using the better eye or the best eye in terms of visual acuity. So the answers option is the same again. That's it, perfect. So we've got the poll up again. Let me just move this out of the way. There we go. So you're using the better eye. What category do they fall into? And then if we can get the answers in. So we've got 11% who've said severely sight impaired or blind, and majority of the votes going to partially sighted. Yeah, actually, I'm sorry, but I have to say that I've actually tricked you for this one. So this one's actually normal. And the reason is that if you look at the better eye, which is the left eye, which falls into 636, they actually still have full fields. So if their vision is 636 in that eye, which is here or worse, they need to have a moderate field defect in order for them to be registered as partially sighted. But their field in the left eye is actually full, which means they're not eligible for that. So although you've got your mind on one thing, which is sort of looking at registration, don't forget about normal patients as well. So or not normal, but this patient wouldn't be eligible to be registered. So I apologize, I didn't give you the option for normal on that one. But yeah. So in terms of thinking of causes of visual impairment, the biggest one you'll tend to find is actual uncorrected visual acuity, uncorrected refractive error, sorry. And then we also have cataracts. So in young patients, you're also thinking of congenital cataract, glaucoma, corneal opacities, diabetic retinopathy, age group, trachoma, again, affected mainly by underdeveloped countries, and macular degeneration. So after sort of finding out or thinking about the pathology and how it affects the patient, you also need to think about what impact it has on them a central scotoma, and do they still have their peripheral vision, or is it the opposite? So do they have loss of their peripheral vision but still retain their central vision? We're also thinking of pathology or lesions that affect the visual pathway. So for example, if they have a stroke, does it affect one side of their vision? Or does it totally affect their vision, such as cataracts? And you also need to think about these defects as absolute or relative. So in absolute, it's one where however bright the stimulus is, you get no response at all. And in relative, it is a reduction in the response or sensitivity. Are they also aware of is the patient also aware of the visual field defect or not? So in the case of a retinal detachment, they would be, but we also all have a natural blind spot that we're not aware of. So is it positive or negative? And then in the case of glaucoma, you're also thinking of at what stage they're at. So is it just a nasal step, or is it the start of an arcuate defect, or is it sort of end stage glaucoma where they've totally lost their peripheral vision? So in terms of prevalence, so there was a study in 2017 which looked at the global estimate and trends of global blindness, and they found that in 1 billion people globally, that is, that have visual impairment, it could have been prevented or is yet to be addressed. They also found that the majority of it, again, was due to refractive error, followed by cataracts, glaucoma, corneal opacities, diabetic retinopathy, trachoma, and loss of near vision or uncorrected presbyopia. And then there was also a study that looked specifically in Nigeria, and they had a sample of around 15,000 patients that they looked at, and they examined 13,000 and a half approximately, which is 98% of those patients actually had vision in one eye at least that was worse than 612, which is a big number, a big percentage of that. So they found in the study that 84% of the visual impairment was actually avoidable. Again, probably falling into the uncorrected refractive error or cataracts. So we've got 57% of it accounting to refractive error and 43% accounting to cataracts. And then this sort of map shows how the prevalence of it affects different parts. And again, majority is in the Africa region, Middle East, and sort of into India. So the consequences of visual impairment actually affects people in many aspects of a patient's life. And you need to think about that and have that at the back of your mind. So any low vision treatment must include a comprehensive look at their vocational needs, the educational needs, social needs, psychological needs. How does it impact them financially? Optometric, so what can we do to help and reduce that, and also their medical needs as well. So this is sort of like a multidisciplinary approach to low vision care, and we sort of need to be able to communicate with other optometrists, ophthalmologists, dispensing opticians with low vision diploma specifically, social workers, occupational therapists, in order to try and help and support low vision patients as best as we can. So if the impairment is not avoided, then we definitely will be involved more in the assessment and the prescription of low vision aids, specifically magnifiers, telescopes, spectacles, microscopes, etc. So our role mainly is sort of early detection of pathology so that we don't end up in that route, assessment and the prescription of appropriate low vision aids, and also the use of low vision aids, so training them to be, in order for the patients to be able to use it correctly. So we have to sort of identify any problems that the patient is having, assess what the patient can currently do, and then provide help in order to achieve what they want to be able to do. So looking at the low vision eye exam, I think I'm running low on time, but I'll try and sort of whiz through this as much as I can. So we've got refraction, supplementary tests, task analysis, which is sort of looking at what they can do and what they want to be able to achieve, determine magnification, and then thinking about what low vision aids are best or appropriate for them, and in order to be able to carry out the tasks that they want to carry out. Other non-optical aids and advice that we can help them, referral if appropriate, and then follow up arrangements. So we don't just see them for one consultation and leave them as it is. Sometimes they get out of the habit of using the low vision aid, or they might forget how to use it, or it might not be appropriate for them anymore, or they pick up a new hobby, or something changes, or their lifestyle changes. We need to be able to sort of support them throughout. So in terms of initial observations, observe the patient as they enter the consultant's room. But you also want to ensure that they have a clear path to the waiting area in the consultant's room as well. So do they attend with a relative, a carer, a guide? Do they have a guide dog? Do they come with a cane? All of these are observations that you can pick up without even speaking to the patient yet. And they give you a lot of information in terms of the patient and how they're coping and dealing with their current condition. Are they bothered by lighting, whether it's natural or artificial? Do they have other physical infirmities, mobility impairment, hand tremors, hearing impairment? Do they appear to be using eccentric viewing? And then thinking about independence and social situation. How did they get to the clinic? Did they come alone? Did they come in a car, public transport, taxi? Living conditions, are they living alone? If they are, and they've lived alone for a long time, they're probably still able to sort of and continue living alone. They're probably well adapted and have found ways to carry on doing that and be able to live alone and do the things that they need to do without as much support. Occupation. Again, how can you support them? If, again, it varies if it's a condition that is congenital, such as congenital cataracts, or if it's an acquired condition and they were working previously. For example, someone who's diabetic and they're a teacher, they suddenly become a low vision patient. How do you support them then? Are there any other support groups available, or do they know anyone else who's a low vision patient, and they sort of get advice and support from each other? Current status, so in terms of history and symptoms. So this is a critical part of the examination. Again, content is going to vary from a normal examination. It'll be longer and more involved, so avoid rushing the patient. You will have a lot more questions to ask them compared to your normal routine eye test. So thinking about the current spectacles, date of the last refraction, if they've had one previously, age of the current spectacles, distance or near, do they find them useful or not? Again, same with low vision aids, if they have any at the moment. Are they able to watch TV? Can they recognize people's faces at a distance? Can they see well enough to get around unaided? What's the smallest print that they can read or they can see? And then looking at the nature of the condition. So is the patient aware of the cause of their visual impairment? A lot of the times you'll tend to find that people don't actually fully understand the condition and why they're a low vision patient. So it's taking the time to explain that to them. Again, thinking about which part of their vision is affected, central or peripheral. And that affects the visual aids that you recommend. So the visual aids or the advice you'd give a patient with macular degeneration, it's different to that of a patient who has advanced glaucoma. So in AMD, you'd be to increase the magnification, utilize the healthy areas of healthy retina. You could advise them to get a bigger TV, larger print, use eccentric viewing. However, you can't advise eccentric viewing to a patient who has advanced glaucoma. So thinking about how it affects them, it again affects the advice that you give. Duration. So when did they first start with the difficulty? Is it congenital or acquired? So again, a lot of the times congenital, they tend to be sort of better adapted to acquired, to those with acquired conditions. Again, think about the condition. Is it stable at this stage? It affects the prescription that you give them, the low vision aid that you give them, the advice that you give them as well. So all of these things are affected if the condition is not stable. So you might want to wait for a little bit until it sort of settles down before giving them a low vision aid, or you might give them something else to attempt low vision aid to keep them going for a little bit whilst it changes, or they might require more visits to the clinic and changes in low vision aids as well as the condition changes or progressively develops. Again, treatment. So if they have wet AMD and they're having treatment, that will alter their vision and the visual acuity and the refraction. So in terms of general health, you're thinking about conditions such as arthritis. So if they're unable to sort of hold low vision aids sort of as well, handheld magnifiers and certain low vision aids, what other options do you have to be able to give them? Again, with Parkinson's disease, diabetes, again, that will change the refraction in their vision. Depression, they probably might be less likely to use the low vision aid and probably less likely to turn up for appointments and miss appointments. They might require more support than those without depression. Alzheimer's probably might require more training and sort of repeating how to use the low vision aids again. Ability, so what are they able to do at the moment? Do they cook on their own, or do they get someone else to cook for them? Are they able to see the dials on the cooker, read ingredients, and sort of packaging, or sort of see the recipes? I know that a lot of Africans don't really use recipes. They'll just say, what's that? Everything's sort of measured by eye and hand. So yeah. Again, hobbies, sewing. Do they like to sew? Read. You're always looking at what they're able to do and what they want to be able to do. And the aim is to try and help them get there. Again, thinking about reading, newspapers, books, packaging, communication, sort of using telephones, writing, signing for things as well. Do they have difficulties with that? And then quickly, in terms of recording visual acuity, because they're low vision patients, you won't always be using the chart as the exact distance that you would for a normal routine sight test. You probably might need to reduce the working distance. So how does that affect the recording of visual acuity? So if you were to drop or reduce the distance to 3 meters, you'd be writing 360, 1.5, 1.5 over 30, and then 0.5 again, 0.5 over 10. So don't get carried away in terms of recording 620 or 660. So always adjust to what the distance is. And again, lastly, adjustments for viewing distances, because it's also affected. So if you reduce it by 3 meters, you'd be adding minus 0.25, and then 2 meters adjusted by minus 0.50, 1 meter again adjusted by minus 1. And that's because you will have overplus the patient by reducing that distance. So in summary, take time to explain the patient's condition. Remember that the hospital clinics are pressured and the patient might not feel willing to ask questions there. Things are usually pretty rushed. You're more or less in and out. So they do spend more time with us as optometrists to go over conditions and help them understand how it impacts them and what they can do to ease things. And they also a lot of times tend to forget about what has been told to them in the hospital. So it requires us to repeat things a few times. It's also a good idea to have a family member or a friend or a carer present in the consultation, just so that they are aware and they can pick up on some of the information given as well. And I think that's me done. I apologise for going over the time, but yeah, I hope that was a benefit. I know it was sort of fairly rushed. Hopefully in the next webinar, I'll be going over the actual refraction part of it and more in depth in terms of the eye test. So this was mainly covering the case history and just the basics of it.